Dear colleagues and participants, thank you for joining our webinar series. Today, our topic focuses on risk communication and community engagement in epidemics, lessons learned from mpox, MVD, and Ebola response in Africa. Thank you for joining us today. We'll have a rich program, so we'll move on first with our key housekeeping. Kindly note the WHO Code of Conduct, as the WHO remains committed to enabling events which everyone can participate in an inclusive, respectful, and safe environment. And these are the values that the organizing committee, the IMST, capacity building sub-pillar group is carrying throughout this webinar series as well. So WHO events are guided by the highest ethical and professional standards. So kindly note. We will look at some of our housekeeping specific rules. So key remarks. So interpretation is available in English and in French. So you'll note your globe for the interpretation in English and French. If I'm not mistaken, today there might be Portuguese available as well. Please look at the menu fully. Please use the Q&A for questions regarding the specific presentation. So if you have questions on one of the speakers' presentation content, so please use the Q&A button and option for that. For any other questions, then please use the chat for logistic issues. If you're having issues with translation logistics, please use the chat. So we would not be able to filter questions that are raised in the chat, unfortunately. This session is being recorded, and by attending, you're consenting to this session being recorded, and I hope and trust you're hearing me well. The session materials, including the session's recording and slides, will be emailed to the participants in the few days following the webinar. And your feedback is important to us, so a survey will be shared in a follow-up email. Pour nos participants francophones, l'interprétation est disponible en français. Veuillez noter le globe, l'icône du globe, et sélectionner la langue de votre choix. Et si vous le souhaitez, vous pouvez
So interpretation services are available in French and English and Portuguese, and remember to switch off the original so that we can follow interpretation. For the other items, I'm sure that the interpreter has done their work, and you can use the Q&A for questions regarding topic and presentations, and for any other logistical questions or technical questions, you can use the chat. And the material is being, this session is being recorded and it will be shared later via email.
And please take notice of our data use. So Project ECHO collects registration, participation, question answers, chat comments, as well as poll responses for this webinar and shares them with WHO. Your individual data will be kept confidential, and these data may be used for reports, maps, communication, survey, quality assurance, evaluation, and also to inform any new initiative. Next. So this session focuses on, as I mentioned, RCCE, and the communities remain at the center of the pandemic response strategies. They need to be involved throughout all the stages of pandemic response planning, monitoring, and revision. So today's our session's objective, we have a very rich agenda, and our first objective is to review RCC strategies used during the recent mpox, Marburg, and Ebola outbreaks in Africa to strengthen surveillance and community response efforts. We will also explore practical approaches to managing community feedback and infodemic as part of an effective community health surveillance. And finally, we will highlight coordination mechanism and country experiences to support integrated risk communication and community engagement during public health emergencies. Next. We have a very rich agenda today, and as we have gone through the housekeeping and objectives, we will first have an overview, a setting the scene point with Dr. Julian Anoko. We will have role of community engagement in epidemics by Tiaba Fame. We'll look at managing infodemics, the lessons learned from key outbreaks and epidemics in Africa with Yara El Mousai. We'll have a short first initial 10-minute Q&A session. And again, kind reminder to use the Q&A for this purpose for topic-specific questions. Then after this Q&A session, we'll roll through presentations on coordination mechanism for RCC support in an outbreak response done by our colleagues from Africa CDC, Kelvin Gishia. We'll have two country experience sharing, one from Burundi Red Cross, and then another from Tanzania Red Cross. And then we'll have a plenary Q&A session with questions and comments and your participation, as we hope to have also, we hope forward to hearing from all of you as well, as much as feasible and as time will allow. And we'll promptly close. Hopefully we'll keep in time. We'll be next. Thank you. So we'll have, as I mentioned, several key speakers. First off, we'll do a general introduction. Please note that we will also be sharing these biographies for your further perusal. But first, we have Dr. Julian Anoko from WHO Afro RCCE team lead for emergency preparedness and response, PhD in social anthropology, over 20 years of experience and a lot of expertise to share with us. Then we'll have Tiaba Fame next. Tiaba is, next slide, please. We'll have Tiaba Fame, who is Senior Community Engagement and Accountability Advisor for the IFRC, International Federation of Red Cross, Red Crescent Societies for the Africa region, based in Dakar, Senegal. She is a multilingual strategic community engagement expert among many expertise in her portfolio. Next. We'll have next Yara El Mousai, who is an experienced emergency and infodemic management specialist with 14 years in nonprofit and UN agencies experience. She's currently serving as country support lead for the Africa Infodemic Response Alliance, a WHO Afro supported network for infodemic management. Next, we have Kelvin Gishia, a technical officer for RCC and advocacy for Africa CDC, has also wide experience and expertise in immunization programs among other fields. We'll also have among our panelists today, next slide, please. We'll have Etienne Ndikukio, who's a lead for public health relations and strategic partnerships for the Burundi Red Cross. who will be among our speakers today. And last but not least, we'll have Dr. Hilary next. Dr. Hilary Ngude from the Tanzania Red Cross is the head, the director of health services for the Tanzania Red Cross Society, with a rich experience in addition to his medical degrees and masters. And myself, I am Dr. Danielle Dummerson. I think I've presented all our panelists for today. Your moderator, yours truly, I'm Dr. Danielle Dummerson. I'm health delegate. I am knowledge and learning coordinator for SLL specific programming, and I am happy to be your moderator for today and to start off with this insightful discussions around RCCE and the lessons learned from Africa. Without further ado, we'll call on our first speaker to further set the scene, Dr. Julian Anoko.
Thank you very much, Dr. Daniel Domesan. Good afternoon, everyone. So I will set the scene presenting an overview of RCC interventions during outbreak response. Slide, please. Slide again. Next slide. Thank you very much. So before starting, I would like just to introduce you to the WHO Community Engagement and Resilience Regional Strategy that was adopted by 47 member states in 2023. This strategy is really putting the communities at the center of all the emergencies and all the health operation, like primary health care, health promotion and social determinant, and also emergency preparedness and response. So I'm not going to go through all the details, but as you can see, the main objective is really to support member states in engaging communities for healthier and more resilient population by fostering a relationship of trust between stakeholders to promote health and minimize the risk. This community engagement strategy is really like putting the community in the middle of all the intervention, but this at the high level strategic and political decision maker. Slide, please. So when we partners, we respond to emergency, the first thing that we do is that we coordinate, we put in place a coordinated strategy approach together. So what we do, we produce, we share strategic guidance and tools. We support countries to develop and implement their RCCE national plans. We build their capacity of country experts, but also of the overall decision makers and administrative and political decision maker. We can also be deployed as search teams to strengthen the response in the field upon request from country, and also after analyzing the gaps that we see in the country during an emergency response like mpox, Ebola, or Marburg. So on the pictures, you can see some of the guidance that we have shared, some of the fact sheet that we have shared, a lot of documentation that we have developed that we share with the country, and we try to support the countries to implement those guidance, because this is really important to work under the guidance, because all the guidance are written, and make sure that the countries are implementing this guidance. Next slide. So these are the strategies that I'm going to present. As I told you, is an overview. All my colleagues, the speakers that will come later, they are going to go deeper into each strategy. So we use community feedback to listen, to build trust, maintain trust, and to respond and be accountable to our communities. So in the picture, you can see the young people that are really involved. This is a program led by UNICEF, which is called the U-Report. But we also have all this work on the field with the IFRC volunteers that are in the field, the Red Cross volunteers in the field that are really engaging community on a daily basis in face-to-face work, and they visit them and they share the information with them. The second strategy that we implement is the infodemic management. Infodemic is simply as too much information, including false or misleading information and online, or in physical environment. We have an institution called IRA. IRA is the Africa Infodemic Response Alliance that is hosted by WHO Regional Office for Africa. IRA is our lead in terms of managing infodemic, and each week, IRA will produce us a bulletin that you can see with the trends report for week to understand how this overabundance of information is affecting people to take the good decision for their health in the countries. We also use our strategy, the behavioral insight. You know that to engage the community, really implement risk communication, you need to know your communities. And for that, you need to map the existing community structures, their certain capacity. And after that, we conduct behavioral action research to generate evidence on the social, environmental, and behavioral determinants of health and well-being, including causes of ill health. Slide, please. The next strategy is community engagement that we are implementing as partners in support of the countries during emergency outbreaks. So the community engagement is you have to empower your community. Once you empower the community, you put in place a community building strategy. You share with them the scientific information, the knowledge for them for you to make sure that they understand what is the risk. And so they can take the good decision and engage to fight the risk and also to strengthen their community knowledge. So after that, we conduct several capacity building. All the purpose of the community engagement is to build and to maintain trust. From time to time, or as you can see, we put in place the engagement of community leaders and influencers. We also organize community dialogues to really share the scientific information, to listen to them, respond to their worries, and also make sure that we bring all the experts together to come to sit with the community in like partners, and also to give them the overall information, but also receive from our community their knowledge, because they know a lot. They know a lot, and we have to be humble to sit with these communities, to learn from them, and together to co-create solutions on how we can really address the challenges of any outbreak response. Social mobilization, we produce materials, we organize sensitization campaigns. These campaigns can be either digital or social media, or also mass gatherings, door-to-door or face-to-face. So we can see on the right, we have developed risk communication and community engagement messages for Marburg viral diseases, but you can also find these messages for Ebola, for mpox. This is just an example, and we share these messages to the countries so that they can really contextualize the messages and make sure that they translate it into the local languages, making it easy for the people to understand. Slide, please. Now, I'm quite at the end of my presentation. We are also doing monitoring and evaluation. Colleagues will explain also this later when they are going to present. This is an example of what we are doing right now in DRC, the Democratic Republic of Congo, where we have developed a tool, in a portal where all the RCC experts from the district level to the national level are collecting the information on RCC activities and interventions, and they are really filling this into that portal using Kobo Collect, and this information can be analyzed. As you can see here, we can see that how many men have we reached in a period of 3 months with sensitization, how many women we have reached, and this information is mainly used for advocacy towards the decision makers, but also to see if we are really performing well, because you can do social mobilization or mass gatherings campaigns when what people need is community engagement. So with this monitoring and evaluation data that we are collecting from the field, we can really reorient the strategy to make sure that we really respond to the worries and to the situation that is in the field. So I think I'm quite at the end of my presentation. So these are the main strategies that we are using as partners in a coordinated manner to respond to the outbreaks and to support countries. My colleagues will further give you more details of all these this strategy, how they are implemented in the field. Next slide, please. Thank you very much, and I'm available for any questions. As the Dr. Daniel Domesan told you, you can write a question on the Q&A, and I will be very happy to answer to this question for you. Thank you very much, Dr. Daniel Domesan. Over to you.
Thank you. Thank you so much, Dr. Julian Anoko, for beautifully setting the scene for this important pillar of any outbreak or emergency pandemic response, that is RCCE, and for spelling out so clearly some key strategies to further foster trust and build on the community feedback and having a solid evidence base that towards having approaches that are localized, contextualized, and multi-partner. So again, thank you for your presentation. We will move forward to Tiaba Fame from the IFRC with her presentation.
Thanks so much, Danielle. Can you just confirm that you can see my screen?
Not yet.
Oh, okay. And now?
Yes, it's okay on my end. Participants can also confirm in the chat. I see
Very
thumbs up,
good.
we're good to go.
Perfect. Thanks so much, Danielle, and thanks for having me today. So I'm just, so like you said, my name is Chaba. I am the CE advisor for IFRC covering the Africa region. And before I start, I just want to mention something that I think is important, because over the past decades, the share of people that has been affected by disaster has increased dramatically, right? And this trend will definitely continue as the frequency and the impact of climate extremes will continue to intensify. In addition to that, Africa remains the largest infectious disease burden globally, with new and recurrent disease outbreaks, which includes cholera, Ebola, measles. So in that context, I think it's important to remember that the national societies that we work with and we work for in the Africa region are positioned to address these increasing needs. And at IFRC, our role is really to support the national societies to elevate the risk, elevate the role of risk communication and community engagement, but also the impact of accountability and just overall reminding the importance of community mobilization on preparedness and response. So I guess the question that I want us to talk about today and to answer is, why is community engagement so critical in when responding to epidemics? The response earlier, it's because it helps to build trust in humanitarian responders, which is extremely important during an outbreak, when we know that fear and misinformation makes it harder for people to identify which information is reliable, which one is trustworthy. So lack of trust limits community involvement, and people may not want to cooperate in activities designed to stop the spread of the infection. So another point that I think is important here is that raising awareness is not enough. It's rarely as simple as telling people what to do and then they will do it. Behavior change is complex, and we have plenty of evidence that shows that blasting one-way messages don't necessarily change people's behavior and don't necessarily reflect like the beliefs and the conversation that are happening at community level. So we need to engage communities. We need to work with them to understand the social, the cultural barriers to safer practices and to find solutions with them. So obviously there are different ways to engage and to listen, but something that is important here is that it's in our best interests to engage using multiple, diverse, but coordinated strategy. And it's especially important because rumors, unfortunately, spread faster than the truth. So we want to make sure that the information we collect and we share and we respond to does not contradict the real health information, right? So In IFRC recent experience, and later on we'll see specific examples from our colleagues with Burundi and Tanzania, we have seen and we have documented like key elements that actually make responses like quite successful, and that includes data. So especially qualitative data. So data that are collected on a regular basis from different sources. That includes emergency needs assessment, context analysis, perception survey, you name it. But the idea behind this data is that we collect it systematically, regularly, and we make an effort to understand the priorities, the perspective, the beliefs, the context in which communities work around and how it affects their behaviors in relation to the epidemics. So that's the first one. We also have coordination with partners. We face common challenges and common concerns that are best addressed by working together, and we can use that collaborative work and effort to advocate with donors to better support communities. We also have capacity building of volunteers. So that includes like coaching on feedback mechanism, training volunteers, training community representatives so that they become champions and they become, you know, the carrier of the right information. And finally, we have obviously knowledge, development and knowledge sharing, which, involves localization of resources. So tools that are developed with the national societies for the national societies. So something else that has been extremely helpful during crisis is interagency work. So IFRC, UNICEF, and WHO are part of an initiative that is called the Collective Service. And that is a partnership between the three organizations. And the objective behind this partnership is to scale up complementary strength from these partners that deliver RCC in emergency settings. So the focus is usually on RCC coordination, country support for national and interagency community feedback mechanism, but also social science, information management. So just to give you a few examples of the work that has been done by the RCC Collective Service in Zambia and Zimbabwe during the recent cholera outbreaks. So we were able to support and strengthen the RCC capacity of the MOH and also the partners to set up interagency community feedback. We also were able to support the MOH representative into conducting rapid qualitative assessment. In Kenya, for example, we supported through the facilitation of community feedback trainings, support sessions for partners, best practice sessions. Something else that we did that was really successful was the cross-border training with different partners to strengthen national cross-border RCC readiness for 8 countries in Eastern Africa. So overall, what I'm trying to say here is that interagency platforms are crucial during times of emergencies because the work that we do with our partners is data-driven, and it's critical because it helps in terms of generating, analyzing, and using evidence on community perspective to inform national policies and national responses. So maybe quickly something that I can say as well is after years of fighting outbreaks, especially, our biggest lesson learned was during Ebola, is epidemic starts and ends with and in communities. I think that's something that we'll be saying over and over again during this webinar, in the sense that if we want to stop the spread of an infection, yes, treatment is important, but it's not the cure. What really is important is getting a solid and systematic support from communities so that they mobilize their peers, their families, their loved ones into trusting the message that we share and the activities that we implement for them, with them, to save their lives. So in IFRC approach to building trust, that is really grounded in understanding communities' perception and also adapting our responses according to the changing concerns and the changing questions, and just the feedback that we receive from communities. So everything related to, establishing systematic community feedback mechanism is extremely crucial for us because it really helps us like understand perception. And this is how we analyze the feedback that we receive, we act on it, and that's what helps in terms of adapting the programs and the response so that they stay relevant. Obviously, there are different channels that can be used to collect this feedback. And basically, I want to share with you something that we did extensively, not just during Ebola, but also during COVID, and we continue to do. But really, during COVID time, we spent so much time and so much energy and resources supporting the national societies in identifying appropriate and really like realistic ways to collect and document community feedback. So we train over 40 different national societies across the continent, and the national societies share with us their feedback on a regular basis. So we help them with, the coding, the analysis, and we were able to collect and develop regional level information products and discussions and guidance and templates and interactive dashboard like the one that is showing right now, so that at some point we create content and tools that is being used by our volunteers at local level so that they can discuss the feedback, they can respond to it. So obviously, like I said, it's one thing to collect it, it's another thing to actually use it. So all the feedback that was used and the tools that were created were meant to inform operations internally, but also, inform partners, either at global or regional level, within the technical working groups, for example. Like I said, we produce a ton of information projects, fact sheets, videos, campaigns that were used by our volunteers, our emergency teams, and our partners. And we have also collected a lot of evidence showing that feedback can definitely turn into actions that, save lives. And that was the case, for example, in places like Cameroon, where during COVID, but even before, we were getting so many feedback about the lack of water facilities and just the overall difficulties into accessing water. And that was meaningful that led into construction of boreholes. In Ethiopia, where people living with disabilities were completely excluded from the responses. We work with local agencies and local organizations so that they were not only, part of the responses, but also champions. In Ghana, in South Sudan, where the engagement with key groups and the support, the testimonials of survivors, the significant impact as well on the effectiveness of the responses. So we have collected and documented and published many resources showcasing that. So I guess the question now is, where do we stand now and what are we doing now? So we continuously improve and simplify the National Society feedback mechanism through simplified processes, simplified tools, and we have more and more country level trainings that are tailored to really support the coding of the feedback, the use of the feedback, the translation of this feedback into actions, but also regional webinars on the evidence of the impact of this CFM. So I guess this is my last slide, which is really focusing on the key takeaways. Raising awareness is not enough. It never was, it never will be. People act when they know what we're talking about, when they believe the actions that we're talking about will work, and when they are empowered and they feel that they have the capacity to implement the responses that make sense to them. So I guess really that's my conclusion for today. So over to you, Danielle.
Thank you so much, Tiaba. Quite a rich presentation, and I believe we'll be receiving more questions in the Q&A. Please keep the questions coming. what insights on key lessons and ways forward, and those key messages I think you were heard, epidemics, pandemics, and start with communities within communities. And you've focused on, Tiaba, your presentation on data, and that drives us to our next session with Yara El Moussaoui, who will be talking about infodemic management.
Thank you so much, Dr. Daniel, and thank you so much, Tiaba and Dr. Julian, before me for paving the way and setting the scene. And as you will see, everything is connected, interconnected. All of the fields that they differ, but they're all connected to make communities engage in a better way and benefit in a better way. So my name is Yara Al Moussaoui, and I'm the country support lead for IRA, the Africa Infodemic Response Alliance. And today I will be talking more about how we manage infodemics, like Dr. Julian has mentioned, which is the overabundance of information, of conversation. So it's not only fake news, misinformation, disinformation. It's as simple as this is when you have so many people and so many conversations that are being shared, that are being questioned, that are being answered by maybe non-experts. So this is what this is infodemics. Next slide, please. So I will be focusing through in our experience through the mpox, Marburg, and Sudan virus disease health outbreaks within the context of Africa. So what is the Africa, apologies for the typo, not African, the Africa Infodemic Response Alliance, IRA. So when I talk about IRA, it's I'm very happy to talk about it because it's a model that many of the people that we worked with have benefited from. They try to replicate maybe, and also that is a bit unique. So it is a WHO Afro-hosted network that was launched in December 2020 in the full period of COVID-19 to fight the spread of this and misinformation in Africa. So there's 40 members and participating entities. They are very different, fact-checking organizations, UN organizations, INGOs. So we have 8 members, official members: Gavi, Africa CDC, IFRC, UN Verified, UN Global Pulse, UNESCO, UNICEF, and WHO. 6 participating entities: Africa Check, PESA Check, Dubawa, AFP Fact Check, and Midan and Ghana Fact. So as you can see, you have fact checkers, you have people who really are on the ground, are doing the dig up of conversations and the fact checking of conversations. We also some of our donors are BMGF, Bill and Melinda Gates, ECHO, Rockefeller Foundation, and WHO. So it is mostly a network that is funded and supported by WHO, AFRA, and other donors, but we really rely on the concept of that we're not alone, and there's a set of members and partners who support us. And I will mention why this is very important in the field of managing infodemics. Next slide, please. So I will go through now on how is the process of managing infodemics, the overload of conversations process in public health. So number one, the first step, yes, you have prepare and monitor, detect and intervene, and strengthen. And I'll go through it in an overview way, and we'll go through a bit more into details at the next slide. So what does this mean in the terms of infodemic management? We'll take a look at this diagram. So we start with social listening and infodemic insights development. So this is the first step that we have into understanding what is our context. So let's say what is in the field, what people are talking about, what are the conversations, what are the mis and disinformation that are being shared with everyone. So this is, let's say, the prepare and monitoring phase. Our next step is really to, like we understood now, what is our context with our current situation. What is needed from us now is to deliver high quality health information and health and health programming. And how is it done? This is done through interventions. New partnerships are needed to effectively engage with communities. How does it happen? It happens that we understand that there's, let's say, a misinformation that is disinformation that is being shared regarding mpox. That, let's say that, and this is something that we have faced before, that there is HIV antigens in the mpox vaccine. So we understood the context, and now what we need is to intervene. And we intervene by, firstly, we produce the infodemic insights report, like my colleagues have mentioned before, that we have a concrete report that we can use to feed in and to share with other colleagues to let them know what is being talked about. We can also work on content creation. We work also on content creation, which is to share simplified messaging in a very easy and in a very simplified way and a very attractive way as well, visually attractive for everyone. Also, we work through capacity building on strengthening in the, let's say, in the specific country where this information is being highly shared, capacity building on the people that need to be on the forefront. It could be the ministries of public health, infodemic management working groups, fact checkers, influencers, community leaders, everyone who we believe is that needs to be on the forefront of this fight, if you can say so. So we promote also all of these steps that we're taking, and we try as much as we can to amplify this dissemination of these. So by this, we are strengthening the systems, we're strengthening preparedness and prevention, planning policy and systems. And I'll dig, this was an overview, and I'll dig more now into what are the concrete steps and concrete activities, let's say, that we have undertaken. Next slide, please. So for social listening, this is for us to understand what's happening in the field. What are the conversations, to understand the context. So in March 2025, I'll give an example of IRA, what the social listening that we detected. In Uganda, there were several comments that were questioning the very existence of mpox in Uganda. With some people were asking why the virus would not affect certain and specific regions. So some users mentioned a possible return of the curfew, of the COVID-19 curfew, a measure that recalls the restrictions that were imposed previously in 2020. In March 2025, I'm just sharing the most recent ones, and that are related to Marburg mpox and to the Sudan virus disease, is that there was an escape in the RC very recently of more than 500 patients from mpox treatment centers due to the recent conflict in the DRC. And this has caused serious concerns and many conversations on social media and also digital platforms and also in the field. And it was also particularly in Zambia and Uganda, as there were fears of cross-border spread that emerged. Several posts and comments highlighted growing tensions in border areas, with the residents expressing concerns about the effectiveness of surveillance measures and the risk of resurgence in infection, and many, many more. I'll also mention that in Feb in 2025 in Tanzania as well, there were questions about the signs and symptoms of Marburg, and these made up around 12% of monitored conversations. Also in December 2024, I didn't mention this here, in Kenya, there was a high distrust in local Kenyan authorities and were questioning the safety of mpox and livestock vaccinations. There was a lot of skepticism, and there was a high disinformation that was led by a doctor called Dr. Wahume, which raised a lot of eyebrows regarding the mpox vaccination. Next slide, please. So one of the steps that we took is that we led on content creation of something that we call Viral Facts Africa. Viral Facts Africa is the video production that is led by IRA. It is less than 1 minute or less videos that are produced in English, in French, or in any local language like we see here. And it aims at clarifying some of the misinformation, disinformation, also information gaps that we have detected from social listening. It does not reaffirm the misinformation or disinformation that is being shared. So people could not take a screenshot and share it and say, okay, this is what WHO is sharing, but it aims as much as we can in a very clear way to clarify, to rectify, and to provide the right answers. Next slide, please. So other than content, social listening, content creation, what do? We do country support activities. We rely a lot on strengthening the systems, either creating systems of infodemic management or constant strengthening of already set up infodemic management systems. So I'll give an example of what we have currently. What we have. Est-ce que je peux avoir une réaction concrète sur l'infodémie? Ça, c'est un exemple que je vais partager
Can
maintenant.
I have a feedback on infodemics?
What we did is that we made sure to better use the data that we are receiving. So there is a call center that receives questions on mpox. So what we did is that there was a capacity building for this center on how to manage infodemics, how to rightly answer the questions. A Q&A simplified with simplified answers was provided to the call center operators. The operators were trained on how to well answer the questions that were asked on mpox. Also, all of the data that are collected, and these inform the interventions in DRC. So we can say as well, this is another form of social listening, which feeds the reporting, the activities, and also feeds in the activities of the RCCE in the field. An infodemic management guide was also produced, and this guide was also used in other contexts. Capacity building, community leaders are trained. They are religious leaders, pastors, teachers, local leaders. So these are trained on how to detect misinformation, disinformation, how to support their community to answer well, and how to very much support their support their communities onto answer questions. So these voices do not transform and not for them to become misinformation or disinformation. And the media engagement, we rely a lot on our work with the media, press briefing with INSP, multilingual questions and answers document, frequent answers and questions in the local languages, in Lingala and in French and Swahili. And journalists are also trained on infodemics in collaboration with Internews. Next step, please. Next slide, please. In Kenya as well, we organized media breakfasts, which means that we inform on a nationwide level, and we raise the awareness on mpox to the media, and this was transmitted live through TV. We also provided the Ministry of Public Health, when they went live on TV, with the talking points, how to also emphasize on the issue of how misinformation, disinformation can affect the issue of how they can increase the danger of misinformation. So these are many of the examples. Next slide, please. In Tanzania as well, we localized content of Viral Facts Africa into Swahili, and also we trained the call center operators on using the guide that I've mentioned before, like we did in DRC. Next slide, please. So the challenges, I'll go very quickly. I still need 1 minute, and I will close. So many of our challenges is to measure the impact. What if we are doing is correct, yes or no, and how we can measure it. Disinformation, misinformation, they it transmits and it travels very, very quickly. So it makes it challenging for us to monitor, to deal with it, and to react very quickly. Some regions in many African countries do not have access, do not have high data penetration. So it makes it more difficult for us to get the right data, to know what is being discussed in the field. Localizing content is not always easy, especially that we need to validate the translation. And even with the great support that the ministries that they provide to us and we provide to them, there are always limited resources and sometimes turnover. So they are not able to take on the full process of infodemic management, which is really not an easy one. Next slide, please. And this is the last one. What are our lessons learned? When you strengthen the system of infodemic management in a certain country, it facilitates all of different tasks. Instead of going that we need to focus now on content creation or on social listening or anything, when you have the process and you have a strong infodemic management working group or a strong unit in the Ministry of Public Health or good collaboration mechanism with the fact checkers and other organizations, this makes it more sustainable and easier for you to have a system for infodemic management. Collaborating with fact-checking organizations is always a great thing to have. And with other cross-sector collaboration with other colleagues from the organization, UN organization or INGO you work with. And what's very important for us, okay, we're staying updated with infodemic management updates, but also to invest. We're investing in knowing more about AI, artificial intelligence, climate change, and how it affects on the dissemination of mis and disinformation and on the infodemic management stage overall. And thank you very much, and apologies for taking a bit of time. Thank you.
Thank you so much, Yara and Musai, for this very insightful presentation. And you're all welcome to ask further questions via the Q&A. For now, most of the Q&A questions have been answered, and we are done with our first session of 3 speakers who have had a common thread talking about the importance of trust in maintaining and sustaining trust. They have had in common the importance of evidence and data and continued use of that evidence to inform decision making. Our 3 speakers also have talked about continued monitoring, the measurement, monitoring and impact measurement as well. So those are key points, I think. Despite different topics, those are commonalities among our speakers. And I do not see, let me see if there are other questions. Okay, you have one question for you, Riara. How do we assess qualitatively the impact of infodemics on vaccine coverage? That's first half. And then how do we also measure the adoption of measures of public health when a community is affected? I hope I'm translating directly from French, so I may need to repeat. So how do we assess qualitatively or quantitatively the impact of infodemics on vaccine coverage and on the actual uptake or adoption of public health measures in a given community? Over to Yara.
Okay, thank you so much. I will talk about quantitatively evaluating the impact of infodemic on vaccine demand, on vaccination acceptance. So what we did is that, as I mentioned, always monitoring the component of monitoring as in all fields, and my colleagues would talk better regarding this. It's always challenging. However, we have we try as much as we can to evaluate it both qualitatively and also in quantity. So what we do is that we rely firstly on social listening. The social listening, what's great about social listening, especially the online one, is that it doesn't necessitate a lot of high resources. So a person or two who have good access to good tools can really get an insight of what is being discussed. So what we do is that we monitor from at the first period is how many people are asking questions regarding the vaccine. Is it questions, normal questions, or is it doubts, or is it sharing misinformation or disinformation on the vaccine, let's say the mpox vaccination? And what we do is that we take it when we start with disseminating the content, collaborating more with the Ministry of Public Health, or especially with fact checkers and influencers, we assess, let's say, week 1, week 2, week 3, the course of these conversations. Are they decreasing in a way? Is the positive and the negativity, is it decreasing? If yes, okay, that doesn't indicate in a way also for us to be always open that these people, they went off and they took the vaccine. Maybe it's still not trendy, the subject by itself, but at least we're trying to understand if it's still the negativity, the negative questions and the misunderstanding are still persistent. So this is one that we could use. The second one is through our colleagues who are more in the field, the epidemic manager focal point who is in the field. We assess through surveys with any post capacity building session that we do, is that we surveys, we try as much as we can to understand if their positions vis-a-vis the vaccine has also changed. And also I'll get back to the social listening, not only quantitatively but qualitatively. We try as much as we can to do a sentiment analysis of the comments, because this also helps us to understand what people are asking. And these voids, the questions that are being asked, they pave the way for us to our content creation. So I hope I've answered your question. It's all, let's say, it's different steps that we undertake. So post-assessment and also the social listening and the sentiment analysis that we do is that really helps us to keep an eye on the situation. Thank you.
Thank you, Lara. And I believe you've answered the question that came from Vicky Mbuyu. Please keep the questions coming, and I'm talking to our speakers, our first 3 set of speakers, to continue responding the questions in the chat as we move towards our next speaker, next set of presentations. And I think all 3 speakers, 3 panelists all talked about the importance of multi-stakeholder, multi-partner, multi-actor collaboration and coordination, and precisely now we're moving to our topic on coordination. So Kelvin Gichia from Africa CDC, over to you for your presentation.
Thank you so much, Dr. Daniela, for that. And also thank you for the previous panelists who have talked before me. Yeah, I want us to probably shift gears now to, as colleagues mentioned, the strategies, the various strategies we have for RCCE. But now, how do we ensure these work in tandem or in alignment with either infodemic management, social mobilization, and other strategies? So my presentation today will be focused more on the coordination aspect of RCCE, how we've been coordinating a few emergencies for mpox and Marburg, and also what we are learning as we move forward, and also the future of coordination for RCC across the continent. As you know, Africa CDC is tasked in terms of coordinating and convening. So next slide, please. Yeah, I think we all agree that coordination is a very important aspect for RCCE. As I mentioned earlier, that there's a lot of misinformation flooded. Our communities are flooded with misinformation, one either accurate or sometimes inaccurate. So These efforts sometimes, if we are not coordinated, can be fragmented, leading to more misinformation and also duplication of efforts and also wastage of resources. By aligning partners, we believe that there is clear, consistent messaging. We also optimize resources and also, as colleagues mentioned, we'll build trust in our response. At Africa CDC, we are basically trying to emphasize across the continent, the continental level and also at the regional level. For this coordination, we know there are small coordination level at regions. We support these forums and in terms of building their capacities and also providing sometimes resources to be able to have a coordinated approach in regional outbreaks. Next slide, please. Coordination, how do we look coordination at an emergency kind of settings? I think in emergency, RCCE serves two critical functions. One is the technical expertise kind of approach, ensuring messages, as colleagues talked, messages are clear, timely, and community focused. And then there is also the operational side of coordination, ensuring that government, partners, and all stakeholders are working in sync. I think, for example, across the mpox response, which is currently ongoing, we've seen the approach where partners have come together to work in sync, of course, supporting the governments in the various response region. I'll mention about the ISMT in DRC, where is the regional coordination for mpox being led by Africa CDC, WHO, and of course from partners. We are trying to support governments across the continent who are responding to the various outbreaks. That is like our EOC, which is currently based in DRC. Next slide, please. So I want to focus the coordination levels for RCCE. As I mentioned earlier, we have the regional kind of coordination where the regional level, at the continental level, we bring partners together and they are able to guide some of the responses they have. For example, for mpox, we are working with WHO, IFRC, IOM, and UNICEF to coordinate at the regional level. But also we have at the country level, my colleagues from the country will talk after me and emphasize on this. The aspect of coordination at the country level is quite different and unique. We find that we want to involve local partners more and let local authorities lead the response. They know the context better than the colleagues at the regional level. So we would want at the country level local partners to lead some of the response. They have deeper knowledge and insights about the communities, about the cultures at that level. And community engagement is also person-centered and use of people, local influencers, community leaders is encouraged at this coordination level. Next slide, please. So I mentioned about the ISMT, where we are coordinating with different partners. For the first time, we are working together with the WHO for the mpox and other outbreak responses. We have one plan, we have one budget, and we have one MNE. We ensure we have this weekly coordination meeting for the RCC pillar. Of course, all these efforts are aimed at supporting governments across the continent. Next slide, please. Yeah, I also want to maybe talk about the aspect of coordination. We have the public health RCCE community of practice. It's also a coordination approach where we have all the 55 member states from the continent coming together as experts to discuss, to align and to discuss about the approach RCCE want to have. And this has a very steering committee with regional representative. The community of practice also has clear terms of reference and also a secretariat hosted by Africa CDC. So the community of practice continues to share knowledge through webinars, also in-person trainings and expert discussion and collaboration. Next slide, please. So, what are some of the good examples we've seen? As I mentioned, the community of practice was started in 2020 during the height of COVID-19. I think I've mentioned this. So let's go to the next slide, please. For this, some of the objective of the community of practice is to strengthen RCC across member states, building their capacities, and also providing a platform for experts to engage, share experience, and improve intervention. This was witnessed during COVID-19. And we are also looking to do a stock-taking kind of exercise next month to understand what are the lessons we've learned and the approach we want to go moving forward. I think the member states will come together and decide the approach we want to take in the next 2 years for the community of practice. Next slide, please. I don't want to focus on this slide much. I know most colleagues, I think Yara mentioned some of the challenges we are experiencing or obstacles around RCCE coordination. Of course, we know the fragmented coordination and leadership or lack of sometimes leadership structure among partners and stakeholders. Of course, resources. We have also weak community engagement structures. And poor integration with other emergency pillars. Sometimes you find we are not in sync with other pillars during emergencies. Next slide, please. So these are some of the effective RCC coordination I can talk about during the Ebola response. Africa CDC was able to work with partners to support local teams. And also during many eradication campaigns, polio campaigns and immunization campaigns, we've also been able to use this coordination aspect to ensure that diseases come to a halt. And also COVID-19 vaccine uptake. Next slide. So as I mentioned, what we are looking for in the next coming months is that we are going to review the community of practice, RCC community of practice, to enhance effectiveness. We are also planning on an exercise of mapping all partners across the continent to strengthen collaboration and know what partners are doing in the field. And also, we are also advocating for increased RCCE funding in national budgets. We are doing this through, in few member states, we are building capacities in terms of advocacy and building investment cases for RCC to be incorporated in national health budgets. We are also planning to have a side event during the CPHI conference this year, so where we bring all the experts around to share experiences and discuss or brainstorm on ways forward. Next slide, I think the last one. Yeah, these are just a conclusion. For RCC to be effective, it must be well coordinated, resilient, and community-driven. And Africa CDC remains committed to leading the RCC efforts across the continent and supporting member states. And of course, we are planning to develop the first continental RCCE strategy and guideline to guide member states across the country. Thank you so much. Over to you, Daniel.
Thank you so much, Kelvin, for this overview of the coordination mechanism. Without further ado, because we're running behind schedule, we will call on our next presenters from, we have first country experience for Burundi. And please, kind reminder to our speakers or to our colleagues, panelists, to answer questions in the Q&A. Several for you, Yara, as well are already on there. Over to you. Country experiences. First, we'll have for Burundi.
Merci beaucoup. Bon après-midi à tous. J'espère que vous.
Thank you very much. Good afternoon, good evening. I hope that you can hear me.
Parfait. Je vais vous présenter,
I'm going to share with you the activities in terms of mpox response with the Burundi Red Cross.
Alors, en termes de promotion de la santé à
The
l'échelle
first activity is the health promotion at community level. To carry out sensitization, community sensitization, door to door by volunteers. So the volunteers go to the communities and try to sensitize households, schools, etc. And at the same time, we broadcast
autre chose ou caravanes mobiles à travers des véhicules
using our vehicles which have loudspeakers to broadcast those messages. We also have flyers and posters in most villages in partnership with the Federation and UNICEF. These posters go to the lowest level, the centralized level, which is called Colline in Burundi, or village. These are some of the posters. You can see vehicle with the loudspeakers to be able to broadcast those messages. And you can see also on the picture, the pictures, volunteers who are visiting households to share those messages with families. I was talking about radio shows, road shows. We have already covered more than almost 400,000 people, including more than 170,000 men and 224 women. In terms of mass awareness creation, using volunteers in markets and other public spaces, we have sensitized more than 1 million people. For door-to-door initiative, more than about 500,000 people were involved, and in schools we have covered more than 500 school children, and as well as marginalized groups, particularly the sex workers, where we have interacted with about 12,000 people. And the most important and the most important of innovation is the initiatives for hearing impaired people. We have interacted with more than 5,000 people, particularly in schools where you have hearing impaired school children. And so we have targeted and recruited some volunteers among those hearing impaired children so that they can help us to translate those messages using sign language and be able to broadcast them. In total, using these channels, we have targeted more than 2,500,000 people through radio shows in two ways, particularly pre-recorded radio shows, as well as live radio shows and interactive shows. And those interactive shows enable listeners to be able to ask questions or to react to the shows and ask questions to panelists using telephone, mobile phones, or Facebook channel or other channels, and resource people respond in real time those questions. We have also radio spots and messages had been validated by the Ministry of Health. That's done in Kirundi, in French. Kirundi is the local language. And also broadcast those messages on 4 partner radio stations. There are more radio stations that we partner with, obviously. And these are community radio stations or national radio stations. So our staff, volunteers, and ministry officials have participated in those broadcast radio shows, which in total are 72 up to now. So in a nutshell, that's what we've done in terms of health promotion for mpox, including other activities in terms of community feedback. We have a hotline through which we collect feedback, and those who man that hotline have been trained. My predecessors have already talked about rapid quality assessment. We have a number of volunteers who have been trained on that. And yesterday, the survey results were released, and they are quite positive in terms of increase of knowledge in communities, and the knowledge of this disease has improved. And of course, there are also other aspects which are yet to be covered. We also carrying out a promotion of the hotline, so that if they have questions or if they have messages or any other issue relating to the feedback on this disease, the community members can use these free toll hotline to obtain to receive answers or to be referred to other organizations which can provide the answers. A number of health districts were affected during the epidemics, and we have trained almost 700 volunteers on the management of community feedback. So we are trying to adapt the actions based on the information collected through these community feedback. So I think that's all I had to share with you. Thanks very much.
Merci beaucoup, Monsieur Étienne, de votre présentation et de l'expérience
Thank you very
du
much, Mr.
Burundi.
Etienne,
Et je
for
crois que ça a
sharing
été
the
un intérêt
Burundi
pour
experience.
les
It was
participants d'entendre parler
very
de vos
useful
mécanismes de
for
feedback,
participants
inclus votre
to
univers
hear
jumelé à vos
your
efforts de
community
renforcement de la recherche, des
feedback, how
enquêtes,
you use the
pour
hotline,
consolider
and
l'analyse.
how
Merci
you
et nous
consolidate
passons
the results of the
without
analysis.
further delay, please keep your questions coming. A few questions still open in the Q&A. Calvin, few questions on how to join the coordination mechanism. So we will then go to our next presenter or final presenter of the day from the Tanzania experience. Dr. Hilary, over to you.
A very good afternoon, everyone. This is Hilary Ngude from Tanzania. Am I there? Great. So I'll share with you. Am I visible by video?
Yes, both your video and your screen are there. And if you can keep it under 9 minutes, we would be so grateful. Thank you.
I'll do my best to. So, as mentioned, I'm Dr. Hilary Ngude from Tanzania Red Cross, presenting our Marburg virus disease experience. This is the second one in 3 years. We had another one in 2023. And next slide, please. Next slide. Yes. So it was between January this year, January 15th, when the outbreak was announced by the president, and it was declared over in March, on March 13th, meaning a span of 8 weeks. In total, there were 108 suspects throughout that period of time. 2 cases were confirmed, 8 were probable. In that they had all the clinical signs and symptoms and died before their samples were taken for confirmation. And in all, there were 281 contacts. The index case was in December last year and died on the 16th of January of the same month. The case fatality rate for all the 10 was 100%. The source of the outbreak is still not known, and all the reported cases were from Biharamulo district in Kagera region. Next slide. Yes. So immediately after the Marburg virus disease outbreak was declared, a national response team was deployed. So this one had technical and operational support from the World Health Organization and partners. A response strategy was structured around 11 key response pillars. These were the coordination pillar, surveillance, screening at entry points, laboratory diagnosis, case management, mental health and psychosocial support, WASH, RCCE, research, logistics, and continuity of essential health. Next slide. So the RCC pillar executed capacity building to community groups and networks, multimedia communication and public messaging, radio and TV broadcasting, community engagement and awareness, digital engagement, and social anthropological response study. Next slide. So what was included in the capacity building part was training to community health workers and volunteers, media personnel, women groups, faith leaders, and registered traditional healers. Messages for mass media were developed and broadcast. Implementing partners included the Health Ministry, the National Institute for Medical Research, the National University for Health and Allied Science, the health promotion units at national level, regional and district level, the World Health Organization, UNICEF, the International Federation of the Red Cross, Africa CDC, and others. Activities were presented daily at coordination meetings, and these were excellent fora where every pillar presented what they had done during that day. Constructive criticism was made, and marching orders for the day that followed were issued. Gaps that were identified, ways were sought to address them. Next slide. So the response took place in 3 districts, meaning Biharamulo district and the 2 districts that border Biharamulo. The total population, which is the target population, was 1,477,000. And in the 3 out of the districts, Biharamulo district had 492,000 individuals, and these were our target for intervention. So the TRCS trained 50 volunteers and community health workers on EPIC, WASH, PGI, MHPSS, community engagement and accountability, surveillance, data collection, and reporting using the COBO tool. And these volunteers were deployed to conduct active case finding, referrals to health facilities, health education from house to house, public meetings, focus group sessions, and random individual interviews. Next slide, please. Next slide, please. Next slide. Next slide. I've been asked to skip straight away to challenges so as not to be repetitive in my information. So the challenges include straight away the myths and misconceptions around the outbreak, which impacted negatively on positive behavior change. There were ongoing disease outbreaks in neighboring countries such as Ebola that also pose a risk to Tanzania. And stigma has remained as a barrier to routine interactions with community members returning from isolation and quarantine centers. The source of the outbreak is not yet established. Situational report has been missing important information such as case details, transmission chain, geospatial data. There's been limited transparency and delays in information sharing. There have been delays in disbursement of funds to complete activities on time. The outbreak of mpox in Tanzania, you may have heard that it is also taking place at this moment. We have 55 cases reported. So there's a challenge of mixed messages occasionally. There are cultural and religious beliefs affecting response efforts. There is limited access to digital platforms in remote areas, and there are language and literacy barriers. Next slide. So some of the lessons learned include the negative seeking of access to vaccination or immunization services, the attendance of mothers or pregnant women to antenatal clinics, patients receiving outpatient services. So fewer and fewer people were going to hospitals for fear of getting quarantined, just in case they were diagnosed with MVD. Most MVD suspected cases who turned negative tested positive for malaria. So this led to a lot of false alerts from the public. We used the used available volunteer network, which was trained on epidemic control. This was important because even before resources were made available, the trained volunteers, voluntarily engaged in preparedness and response to the epidemic. At the district level, health professionals showed a lot of readiness to work with the Red Cross, and we were happy about that. And we were happy from the results we got from educating traditional leaders and healers, because once they showed understanding about Marburg, they were able to support us to dispel myths, but also to refer cases that they clearly understood were not within what they could do to help. We also learned that it is important to engage the community and religious leaders in dialogue and also involve them in risk communication initiatives. Next slide. Okay, so the way forward is to train and deploy 100 more community health workers and volunteers in the neighboring districts of Ngara and Muleba. We realize this is not response anymore, it is recovery. We also intend to conduct PGI rapid assessment in 3 districts to understand the impact of the outbreak on social groups and people with special needs. We plan to equip volunteers with minimum standard PGI package in emergency and to increase awareness of available health facilities and services such as counseling to help rebuild trust and ensure communities utilize necessary resources in the 3 districts of our intervention. We also plan to implement hygiene promotion, conduct hand washing demonstration in schools and public places, distribute soap for hand washing. We also plan to continue providing mental health and psychosocial support to the affected communities and to promote unity, healing, and recovery from social stigmas by engaging the community through community events, engaging traditional healers and religious leaders. We shall conduct a lessons learned workshop to which we will invite government leaders, traditional healers, policymakers as well, so that the findings may inform our future interventions to epidemics. Thank you. Danielle?
Daniel?
Apologies, colleagues. Daniel is not available at the moment. Thank you, Hilary. That was a very brief presentation. I'd like to hand over now to Dr. Julian. Dr. Julian, if you are available, could you kindly take over moderation with the Q&A and closing?
Thank you. Thank you very much, Amarashi. Yes, we can go. I have already seen that I'm in the Q&A now, and quite all the question has been answered in the Q&A box. I don't see a question that has not been answered here. Maybe, yeah, I don't see any questions. I saw all the questions here have been answered. Yeah. I'm going through it, and yes, all of them have been answered. Chiaba answered, Yara, myself, and yes, Amarashi, no question is unanswered here in the chat. All of them have been answered. People are asking if the presentation can be shared. Yes, Aditi, I've said that all the session materials, including YouTube video, both English, Portuguese, and French, along with the slide deck and the survey link, will be sent to you in a follow-up email within a few days after the webinar, as is. So Dr. Danielle Domersan is back, so I will hand over to her. Thank you, and over. Dr. Danielle, we were just I was going through
Yes, thank you.
the Q&A.
Apologies, a small issue. There are still, and I believe, and thank you for the participants, and the only open questions probably would prompt us to organize future sessions around RCC in complex emergencies, or infodemics, RCC, and the use of AI, pharmacovigilance, so the adverse events, and RCCE, social media analytics, and quantitative measurements. Those are the few open questions, but that would prompt for full sessions to adequately, I think, cover those topics. And I think the key message we're given to have communities as partners, to have our multi-stakeholder approach, and to move forward into adequate RCC evidence and investments. We're well over time. Thank you for everyone who remain able to join. And wishing we will follow up on any other open questions. We will share all the presentations, the responses, and we look forward to another forum to discuss more in depth on RCC. Thank you very much to our speakers, to the organizers, to our ECHO India team for the and our interpreters for the support, and wishing you the good rest of your day.
Thank you, Danielle. Thank you, colleagues.
Thank you, colleagues.
Thank you.
Au revoir.
Thank you, everybody, for joining. Manjeet ji, please close the line.